So I'd like to you can sit in the back. We'll come back. And we are going to have another question and answer period at the end of the day with all the speakers, as I mentioned. I'd like to introduce our next speaker, Bill Lacy. Bill is the CEO, Associate for Corporate Health Risk Management. He has over 28 years experience in executive and financial leadership positions. He joins us today from New Jersey. And Bill will be talking more specifically about direct contracting for businesses. Bill?
Welcome. Tony. Good morning. Thank you. Thank you, AMD3 Foundation. And this is really a terrific program. And Jamie, thank you for those opening comments. You really lay out the groundwork for direct contracting. Before I begin, though, it's important that we understand that direct contracting doesn't sit by itself, either from an employer side or from a provider side. My background is financial, CFO, small, mid-sized, very large companies, and across a variety of industries. And I was asked to speak last week in Dallas to an audience full of CFOs, private equity fund managers, bankers, attorneys, appraisers, really the advisory team to the CFO on what are the 5 challenges or key strategies, rather, for containing healthcare costs. And Dallas, we like to say Pittsburgh's a unique market. Dallas is a unique market. You've got multiple insurance carriers. You've got many private TPAs. It's not unusual for a company with less than 10 employees to be self-funded. They have been at this for quite a while. So this audience of CFOs, the 5 challenges. One is we got to get you all educated on these issues. I didn't use that as number 1, but that was one. Understanding healthcare costs. And I think Jamie did a great job in laying up some of these issues that an employer faces. I'm going to do a much deeper dive into that from the employer side. Number 2 is unraveling PBM, pharmacy. There is a world of opportunity there from an employer's standpoint. Direct contracting, obviously. Wellness, how do we look at it? We went into a variety of different areas there. And then most importantly was partnering with human resources and engaging and educating the employee. You can't have direct contracting unless you have the employees involved. So we're going to touch on some of these things going forward. But is this the magic? Yes. So this is what we're going to cover. I'm going to start right out of the gate with a case study. I'm going to cover several case studies. These are live employers within our community that are working through this. I want to go through some of the trends that are happening in the marketplace to drive this. Jamie hit several of them, more from a global standpoint, but I'll do a little bit deeper dive into that. The PPO arrangement that we currently have is not working to control healthcare costs. That's why we're finding employers looking for new solutions, because the employer today is the check writer, the payer, and we're seeing new innovation that's coming in. So direct contracting, we're going to look at it from the employer side, both, and from the provider side. We're going to look at the benefits, the obstacles. We're going to go through 7 case studies. These are employers that are, I pulled a few, 200 employees, 400 employees, 500 employees, 1,000 employees. We even brought one that's 19,000. Direct contracting works for any size employer. I'm not saying it's easy, but it's happening. And then some recommendations on next steps. And what I would characterize here in Pittsburgh is what I'm calling nibble around the edges. And I'll get into a little bit more detail on that. So here's the first case study. This is a municipality. None of us want to pay higher taxes, so a municipality struggles with a fixed revenue stream. This one was going bankrupt. It was in a rural community, 500 employees, rapidly increasing healthcare costs. Also, municipalities struggle with something that, I'll just use the initials OPEB. It sits on the balance sheet. It's a liability. It represents all of the retired employees. Back when we were putting this together, we didn't think we were going to live much beyond 65. Well, today, you could be living much longer, and in a community like Fort Worth, Texas, that OPEB is $1 billion. It is a big, big number for municipalities. So what happened here was a direct contract. Sitting down, employer at the table, provider at the table. We're going bankrupt. We're one of your biggest customers. We've got to come up with a new methodology. And the method that was put in here was, Jamie touched on reference-based pricing. This was Medicare plus a spread. And the negotiation was, at what rate can you make money? We want to make sure you're profitable, but we need to survive. So it was a Medicare plus a spread with the local health system. They reduced their, as you can see here, it was just incredible. But it took this entity from junk status, trying to raise financing, into much better territory. And they were able to improve the overall benefits to the employees. So who are we? The Association for Corporate Health Risk Management. We were launched in 2012. We're made up of, today, over 400 progressive employers. They're coming together to find innovative ways to contain healthcare costs. And in an audience like this, our sessions are usually 20 to 40 participants. It's going to be mostly employers and a couple of industry experts, and we'll do deep dives into those 6 challenges that I had mentioned earlier. We limit the number of vendors that come in. We're very selective. We do 1 per industry vertical. We set ourselves up on a chapter basis because many of these issues are local. Currently, Philadelphia, Baltimore, D.C., Dallas, Chicago, Northern New Jersey, expanding this year quite rapidly into several markets. I'm glad Jamie touched upon medical travel. That's going to be a rationalizer in this marketplace. Whether your employees decide to go to Singapore or Costa Rica, that price is going to be out there. The international providers understand price transparency. They will give you a set rate for services. And we have employers that are turning around and going to the local provider and saying, can you beat this or can you match it? And these are low prices and good quality. So just something to be aware of. We'll eventually have 40 chapters across the country. One of the advantages of how we operate is cross-fertilization. Ideas from Dallas, ideas from Miami, ideas from Pittsburgh. And let's bring these together. Let's move them around the country and see if there's other ways that we can benefit. I grew up in 2 deregulating industries. My first job out of school in 1985, so today I guess I'm 30 years in this world, was working for what was known as a non-bank bank. Who's ever heard of a non-bank bank? Well, the Bank Holding Act of 1982 opened up a loophole which enabled virtually every business that wasn't a bank to create a bank. Here in Pittsburgh, a large mutual fund company, Federated Investors, started a little bank, and we were issuing credit card flyers all across the country. This is back when state lines made a difference. We had well over 10,000 commercial banks in the country, so it's a big change. Power industry. I went into the power industry in the late 90s. I developed Pico Energy, which is today Exelon, what was known as enterprise-wide or corporate-wide risk management. We never needed it before deregulation. I built that within Pico. It took a 3-year process, touched every department, and it was a collaborative effort because none of the power companies knew how to do it. So we were all kind of feeling our way in the dark. Lots of collaboration in trying to put that together. I see very similar things happening in the healthcare space. We were doing the opposite in banking and power. We were unbundling our services and then trying to attach some type of fee to it. And yes, we went about it as, this is what the cost is internally, let's add a spread. But eventually that will become a market price. It may not have anything to do what cost is. It's what the market's willing to pay. CNN, great program back in January. Did anybody see it? Situation, he was trying to get his shoulder examined, called around, trying to get MRI pricing. It was the same thing. Who's your insurance company? What's your copay? Ooh, nobody's giving price. It was the question that was raised earlier, spot on with that, and I'm sure you can pull that up YouTube. But he found the pricing in his market $500 to $3,000 for an MRI. I'll tell you, most employers have no idea what an MRI costs that they're paying for. Most employers have no idea what a day in the hospital costs, but this is all going to come. So some of the trends that we're seeing is, I guess the best thing that we're seeing from our association is the positive outcomes when you have a healthcare provider sitting at the table with an employer, and let's try and find a solution where it works for both sides. Bottom line, that has gone a long, long way. Self-funding employers, how many employers are not self-funded in the audience? It is the movement today. And like I said, we have members in our world, 5 employees who are self-funded. They're part of what's known as a captive, but we're seeing them small and large. The school district consortium, we've got a great story coming up. Phoenix, either 13 or 18 school districts, 33,000 total members. Everything I'm talking about, they're doing. And then most employers are underprepared. They're not educated. Another piece of this equation is they've assumed the risk, so they're writing a check for part of it, but now we've created a new entity out there called the stop-loss carrier. Now, in markets where you have an independent stop-loss carrier, meaning it's not part of an insurance carrier, and you have an independent TPA, meaning it's not part of the insurance carrier, because some self-funding, if you're still getting your self-funding through your insurance carrier, we consider that self-funding light. But if you have moved to the point where you have self-funded and you're using an independent TPA, an independent stop-loss, that's moving to a point where we have some employers who have since built enough reserves in their stop-loss that they don't have to carry stop-loss. The stop-loss carriers are starting to put up the red flag and saying, we're not going to pay this claim coming through. And I'll give examples on that. CFO, like I said, I had direct relationships with every vendor except for healthcare. Had an agreement. We knew how much we were spending. I knew who that entity was. Healthcare, I have no idea. It gets poured into a big black hole, and somebody else is handling all of that. And most CFOs like that. They don't want to get their hands dirty. Price transparency, we've heard that. That's clearly, it's healthcare is not a free market. The buyer and the seller don't know what price is until after the fact. This happened in the power industry when we were deregulating. It was a big challenge in California, but I won't go into that. It also expands options. Jamie mentioned travel. 50 miles, 300 miles, out of the country. Employers are looking at this now. You're seeing centers of excellence. You're seeing out-of-network providers who are willing to put price down on the table attract employers to come to their destinations. Take it a step further. Now you can start to define outcomes and employee experience. So it makes a nice alignment with the provider. There's lots of obstacles. You might be able to tell I put them in red. Takes a lot of time because there isn't a standard. I'm glad there's an attorney in the room. All of these agreements are all different. We're interviewing several large law firms right now that we'd like to bring in to set the standard. What should this documentation process look like? We've got employer direct contracts that are anywhere from 3 pages to 10 pages. They're not complicated, but someday they will become complicated. Most healthcare providers are underprepared. I will present in front of providers as well as in front of employers, and that's why we like to bring both together, because who's the point of contact? Small 100 employee company calls local health system and says, I want a direct contract. You're going to get shuffled around. You might end up in managed care, and managed care is going to say, well, 100 employees, that's not too much volume. I don't think I'm going to do anything. So it's something that's coming. We, on both sides of the table, need to look at this as an option. Intermediaries, health insurance brokers, consultants, many of them are not experienced with this, so they're trying to get up the curve. The bankers, the investment bankers, the accountants, the attorneys, the advisors to the CFO, they need to get up the curve. And as I mentioned, no standard in documentation. So what happens from the provider side? Why should the provider get involved? Well, number one, it gives you a closer relationship with the payer. Payer is the employer. And the payer is struggling with trying to contain health care costs, and this can bring a great opportunity. But like I said, it's a full continuum inside the employer. It involves wellness. It involves moving into a self-funded strategy. It's understanding as a self-funded that you can rewrite your insurance plan. You can implement co-pays to try and steer an employee to a certain destination. You could put bonuses into this. There is a lot of opportunity there for the employer. I like to call it less complicated cash flow. As providers, maybe the insurance carrier is paying 2/3 of the intervention, and we got to go chase down another third from the patient. Well, when you're dealing with the employer, that second piece can get reduced significantly, because the employer wants their employees to take advantage of this and is willing to write the check on a larger portion. So the net revenue may not be that different, but the ease of getting that revenue, not having to hire somebody to make all these calls to try and chase down that money, plus you can increase patients. You're going to get an employer, once an employer is invested in this, they're going to send out the great praises, testimonials, and it opens the doors for new services. I don't know what all those new services are, but again, when you're working directly with the payer like this, things happen. The broker and the carrier, if they're not on board, you're going to get resistance. Philadelphia is a great market. Lots of resistance there. But we're finding ways where direct contracting works. Could be lower revenue overall, but you're going to get higher volume. And like I said, no standardization in documentation. So you are building it from the ground up. Now, our association, we have certain paradigms that we can pull from to help employers start off. So key components to why direct contract? Well, the first thing from an employer standpoint is understanding healthcare costs, and I would say 99% of non-healthcare related employers have no idea what they're paying currently. We talked about the charge master. I put up this slide last week to the CFOs. I took up a for-profit hospital out of San Antonio. I think we had 50 things on there. The average cost was 12.6%. So if the carrier is saying that you're going to pay $100, you got a pretty good spread. You got $83 spread on that. I mean, as a CFO for lots of other industries, boy, I wish we could have gotten that kind of margin. Then the carrier comes back and says, well, we negotiated a 50% discount. All right, well, now we're down to $50. It's moving all over the place. There's transparency. There's no understanding of what that real price is. So that's where an employer needs to get educated. And they really get educated when they look at their claims. Really get educated. And I got 4 examples on that one. Because most employers have no idea. These claims are getting processed by a TPA. And if the TPA is aligned with a health insurance carrier, that TPA may not be flagging any of those because we're just, whatever certain touches that need to go, we just push it right through our pipe. There's no auditing process. So from an employer standpoint, we need to create some discipline. The employer needs to understand what its health risk profile is. How many type 2 diabetics do I have? How many knee replacements did we do last year? What's my oncology spend? Things like that we need to get a handle on. The pricing strategies that we have seen thus far are two. Flat rate, so Jamie with the bundled pricing, a great example, Oklahoma Surgical Center. Dr. Keith Smith, he's trying to blaze a trail here. You can find him if you haven't seen that information. He has posted on his website the price for a knee replacement, facility, surgeon, anesthesia, one number. Whether it's me, you, same number, and he's making a movement. Now, are we all going to do that? I don't know, but it is happening. Like I said, outside of the country, you can get that same type of pricing. We have seen within our experience both bundled as well as individual services on a fixed rate basis. Now, certain interventions are tough. Oncology, it's hard to pick one number. But knee replacement, we've got a variance here. I know I can make money if it's here. Sometimes I lose, sometimes I make it, but I know on the most part I'm going to make it in there. The other strategy is Medicare plus a margin. It at least puts a basis on the pricing methodology. The future, I don't know. I think there's a world of opportunity, but again, we need the provider and the employer at the table. It is a partnership. It's working together to make this happen. It's not one or the other. So here are 4 live cases within our association. Middle market size companies. We got a small municipality in there, a restaurant, energy supply company. Situation here is the numbers that you see on the billed charges. This is what was presented to the TPA. The result, I call it negotiated payments. There was nothing negotiated. It's just that was the new pricing margin that was implemented, and these were the results. This isn't calipers. This is your school district with 1,900 employees down the street that saved $3.7 million. Yeah, it's a first time, and now you can continue to grow on that, but these are small to mid-size employers that are making this happen. Roughly, on average, about 70% savings. I could put 100 of these in front of you right now. This is happening lots of places, and they aren't the Walmarts, the Home Depots. These are your local entities that are down the street. Once they learn how to do this, they want to get it done. So what are the other things that are driving for direct contracting? It helps define what the service is, the performance outcomes. We've got Leapfrog out there, but this gets a little bit more granular. Gives an opportunity to create an employee experience. Payment terms. How would a provider like Net30 payment terms? Like every other vendor that an employer works with. And it can get processed through the TPA, or it can just get direct invoice. Unfortunately, we don't have any standard documentation. There's no customized process here. We can tell you the steps that have worked for other entities, but it doesn't mean that it's going to work for everybody. Big part of this process is the employer understanding as a self-funded employer that they can rewrite their entire insurance program. And I'm going to give you a great case in that in a minute. But this final point, if you don't have employee education or engagement, we have employers who did a great job negotiating a direct contract, but then nobody used it. It was a nice thing to have, but unless you get the employees connected, and I'm not saying that's easy, but that needs to be part of it. So I've got 4 more cases here. How we're presented, you're going to see the municipality again. We put it up as what was the challenge that the entity faced, what was the solution that was implemented, and then what were the results. And it's not always about price. I think Tony may mention this later on, but looking at total value proposition can be important to employers. Looking at both the cost as well as what the outcome is. Looking at that total value proposition. So let me take a little bit deeper dive. Let's come back to this municipality. How did it get started? The municipality was going to become Detroit very quickly. So what it required was the municipality sitting down, and this was a full health system, but it was in a rural market. But I would venture a guess that there's a lot of municipalities, school districts, labor unions, public entities that fall into this category. And they negotiated a payment mechanism that worked for both sides. We can't pay you Medicare plus 400%. We can't pay you Medicare plus 400% or more. We just can't do it. It's not going to work. But what will work? And I was making up that 400 spread. I don't know what it was. But I think this eventually came to Medicare plus 35%. And it was a lifesaver. This was a larger employer in that community, very well known, obviously, and this was a rescue operation. The others aren't so dramatic. Here's a great, all right, finally we get a local one. This is out of Philadelphia. This one was incubated within ACHRM. And when I say incubated, we put on a couple of workshops on what is, and we didn't even call it direct contracting yet. We were kind of looking at it as, could this be an alternative benefit model? So we brought in an employer from outside the region. We later brought in a provider from outside the region. We then invited around the table a half a dozen local providers and a half a dozen local progressive employers. And we said, let's come together. We see some models that are working elsewhere, start marching together. Unfortunately, not all 6 made it to the finish line. But this one did. And it's a little challenging. But some of the ways that they made it work is the labor union, this is the local Teamsters, 19,000 members, and oncology, cancer, big issue with them. And it wasn't so much the cost, but it was the experience that their employees were receiving. Kind of more of a number, viewed as a number as opposed to the patient. And so in this structure, yes, there was an agreement. There was defined pricing, and it was off of a, I'm going to use some of my terms. It was off of some type of index. It wasn't a flat rate. The other advantage that the union brought is they were their own TPA. So they're processing their own claims. So a little bit faster getting through this. 800 number for the Teamsters members to make sure that they had a resource that they could go to get questions answered. And like I said, the claims got sent directly to the Teamsters office. I don't know how many employers are processing their own claims, but you can make this work if you're not doing that. They were also able to alter the copay, which drove or encouraged or incented the employees to go this way. So maximum out of pocket, $725. Oncology interventions can be big numbers from the consumer standpoint. This is the flexibility that an employer can offer in structuring its health insurance plan as a self-funded group. Patient feedback. I think this was locked in about a year ago. I think they've had close to 20 go through. And every time a patient goes through the cycle, there's feedback that comes. And they also implemented health and wellness. Again, that integration, what are the other services that we can offer as providers? This is one of my favorites. This is an Atlanta-based entity, went self-funded about a dozen years ago. We presented it to our group early, maybe in 2012. 24 different firms, 1,000 employees. Talk about a conglomerate. Multiple industries. I've been a CFO or a consultant for a couple of them, and I can tell you the cultural differences are radical. Wood products, car dealerships, energy, ooh boy. Trying to develop a unified program for all of those employees was quite challenging. So they went self-funded, weren't getting the data from their TPA, so they made a next step. They started processing their own claims. Once they were processing their own claims, they then saw that the numbers, or the variances in the numbers that they were paying their local providers, brought them to the table to set up a direct contract. And they not only worked in market, but they also found, and it wasn't in downtown Atlanta, it was outside, but they found that there were services, quality that wasn't readily available, and they negotiated, I'll call it travel, a couple hundred miles away, where they would send patients because of the quality of service as well as the fee. This company no longer carries stop-loss insurance, set up reserves, they understood their health risk profile, they built up, it's quite a success story. Average rate of growth for the healthcare cost year over year is 1.3%. Very, very impressive situation. All right, outside of the U.S., how many of us have gone to another country? I went to Puerto Rico a year ago just to tour some of the local hospitals. They're not ready for medical tourism. In a couple of weeks, I'm going to Costa Rica. It's an interesting approach. They have a not-for-profit group that has organized all the components of medical travel, including airline, hotels, transportation, the healthcare, so forth. We're just dipping a toe in the water. We just want to understand what is going on outside of the U.S. And so here's one example. This was a network, this was out of South Carolina. 2007, 22 participating hospitals. The net result is over this 8-year period, they've been able to put in 265 employers. They'd like it to be many, many times that, which is why they have approached us with an estimated savings of 7.5. This is an example of certain interventions out there, and this data is from out of our Florida and our Texas chapters. Average charge relative to what this data, the international hospital is actually out of Costa Rica. And it's roughly, you're looking at a sharp 80% reduction. Now, I'm not saying that we need to go down to that pricing. I'm just saying that employers are seeing this. They're understanding this. They want to know more about it. There are some employers in Florida, for example, who may say, hey, you know what, I can go to Costa Rica for a knee replacement at $12.5 versus you, local center. And when I say $12.5, that includes a dozen PT sessions, among other things, and you're at $66,000. That starts the negotiation, that starts the conversation, which is where we see it going. And at that point, it's... So I've gotten the crook to get out of here, and I appreciate everybody's attention. This is how we've gone through this process. Collaboration, collaboration, collaboration. I can't say that enough. Employers in the room, talking about these issues, sharing ideas, sharing experiences. That's our world. Then let's bring in current paradigms. This is happening here. This is happening here. This is what the agreement looks like. This is what the pricing structure looks like. This is the process we had to go through. This is how we modified the plan. You got to get an educated broker and TPA. I don't even know where to begin on that. If my guess is the broker and consulting community, we're going to see in the next few years a massive dropout in that marketplace. Because talk about price transparency, most brokers and consultants are not transparent, and once that transparency does happen and we know exactly what that fee is, we're going to hold them to adding value to the process. And if they're not bringing innovation, we're not going to hire them the next year. They're going to be like our banker. They're going to be like our accountant. They're going to be like our attorney. We know what the price is, and we want to know what value they're going to be bringing. Same with your TPA. What are my greatest needs? Start there. Develop your strategy. Select services. Primary care is the easiest thing to direct contract. It's like a gym membership. Per employee per month. You could start that tomorrow. Orthopedics, a little bit harder. Oncology, even more difficult. Work comp. We're seeing opportunities in work comp with bundled pricing. As Jamie mentioned, colonoscopy, MRI, lab work. Kind of get your feet wet. Get started that way. Be careful when you go to reach out to the provider. They may not be ready. Most providers aren't. We're helping educate them through this process. So don't get frustrated. Then the negotiation starts, and that's, like I said, it's got to be two on the table. Legal, we're interviewing several law firms to come up with more of a standard agreement. You got to modify your health insurance plan, communicate to employees, and then track and evaluate. This is a dynamic process. It's not going to happen overnight. It's going to be small steps. It's only going to be one part of your overall strategy. Go back to number one, collaborate with your peers. Thank you, everyone.
Thanks, Bill. And as I mentioned, we'll have a session at the end where all the panels will be up there to speak. So we're going to take a quick break, and let's reconvene at 10:15. If you haven't seen, all the refreshments are in the room and back on my right over there. So see you at 10:15.